The first speaker is Dr. Keith Barton. I think he needs no introduction, the last word in glaucoma surgery from Moorfields, UK. And he'll be covering two very important topics. The first one is on uveitic glaucoma, and the second one is on minimally invasive bleb surgery. And I would like to invite Keith, and you can be comfortable and give both lectures back to back.
Thanks, Tanuj. I was just going to do them the other way around, so I'll now change that. Just give me a sec. Well, uveitic glaucoma, we got the slides, has been something, it interested me, but I was specifically asked to set up a clinic to look at the management of glaucoma and uveitis at Moorfields in 1996, because at that time it was of concern that the patients with uveitis who got glaucoma all disappeared into the glaucoma service, and their uveitis was not properly managed, and the trabs all failed and so forth. So we set up a clinic originally to try and manage the patients with uveitic glaucoma separately from the general glaucoma pool. And with time, that has gradually changed back again, because people are much more aware now about how important it is to control the uveitis. I have quite a few financial disclosures. The main one's a Paul glaucoma implant. Everything in uveitic glaucoma is more extreme than primary glaucoma. Uveitic open angle is more extreme IOP swings than POAG. Angle closure is more extreme than primary angle closure. The disease can elevate the pressure or reduce the pressure, and the treatment can elevate the pressure or reduce the pressure. So the mechanisms can be mixed and all over the place, and you need to clearly identify what's going on, and it's not one size fits all. One particular problem that's not uncommon is the management of angle closure. And then the other one is really the long-term, taking the pressure out of the equation so that the uveitis specialist can manage the uveitis properly without fear of the pressure going out of control, because it's a very false economy to be reducing steroids just to reduce the pressure and then letting the damage get worse. This often entails surgery, and the glaucoma specialist must have the full range of surgical options at their disposal. You know, if you don't know, if you only do MIGS and don't have the full portfolio of glaucoma surgery, you're not going to be able to manage uveitic glaucoma properly. Angle closure, particularly just acute angle closure, which is less common, obviously, but particularly devastating in hot eyes. And it tends to get managed like primary angle closure, which is obviously much more common and is what people are more familiar with. And the problem is that angle closure in uveitis comes in several flavors. There's the acute pupil block type. There's chronic angle closure from nodules, neovascularization, membranes, and there's forward movement of the iris lens diaphragm. So you've really got pupil block, chronic angle closure mechanisms, and you've got the central AC shallowing mechanisms. And these are all a bit different in terms of management. It is worth pointing out that pupil block in uveitis is not the same as pupil block in primary angle closure, this is primary angle closure. It's bad enough, but the pupil block tends to be relative. Pupil block in uveitis is absolute. The pupil's secluded. The iris isn't just in contact with trabecular meshwork, it's in contact with the cornea, and everything's stuck. And if you don't manage this correctly, the patient will go blind very quickly, and it's not unusual to see eyes that are no light perception at 40 years old from this. This is very different from primary angle closure. Here's a case, a 33-year-old Chinese male attended Moorfields in 2009 with rapid reduction in vision in both eyes and severe pain. Corneal edema, iris bombae, multiple KP, lots of cells, and posterior synechia with iridocorneal contact right up the central cornea and no fundus view. And of course, somebody tried to laser PI him, and kind of you can see that they've machine gunned the upper iris with laser holes, and in the left eye and the right eye they managed to get through just about, and they got the pressure under control. And then 5 weeks later, when his medication ran out, he was back in angle closure again. And this is a very typical story with laser PIs in angle closure in uveitis. And what you really need to do is a surgical PI, which of course looks very easy. You open the cornea and you take it out, and there's your surgical PI. But of course, this patient wasn't actually uveitic, and the uveitic ones are much more difficult. In this particular patient, this is the guy I was talking about, the iris is stuck to the cornea. You can mobilize it with viscoelastic and as much as you like, and it won't come out. You really have to spend quite a lot of time trying to get the iris free, because it's not relative pupil block. It's not just going to fall back. It's absolutely glued to the cornea. And sometime later, after quite a while, actually managed to do the PI. Great. Well, what's the difference between a surgical PI and a laser PI? Well, not much really. It's a little bit bigger, that's about it. But the whole point is that a surgical PI means you go to the operating theatre and there are other things you can do at the same time. It's not that the PI itself is any different. The problem is with uveitis is pupil margin stuck to the lens, the iris periphery stuck to the cornea. That's why laser PIs tend to be ineffective. And part of the reason is that there are broad adhesions between lens and iris. You know, there's no continuous space. There may be no space at all, in fact, behind the iris. There's iris adherent everywhere. And this patient had Bombay in 2 quadrants, not 4. And whenever I put in dilating drops, the pupil didn't dilate, but the Bombay reduced in another quadrant. So it's not a continuous space. There's tons of adhesions. So it's not surprising a laser PI doesn't work. Do you think a surgical PI is going to work if you've got the same problem? Well, it's not just the surgical PI. The point is you can do some posterior synechiolisis, which in phakic eyes is generally reasonably easy. And for some reason in pseudophakic eyes, it can be virtually impossible and much more traumatic. So posterior synechiolisis looks very easy here, but it's not always so easy. And you've got to be really careful, or you can really traumatize the iris. And when you do posterior synechiolisis, you can never be 100% sure that they're going to stay broken and that it doesn't adhere again afterwards, which is the other problem. So posterior synechiolisis is tough, traumatic, and of dubious benefit. But you're in there, so you might as well do it anyway, as long as you're not doing too much, causing too much trouble. But it's not like opening a stuck-down pupil at the start of phaco. The pseudophakic ones, as I mentioned, are much more, for some reason, the adhesions tend to be much tougher. And this is one reason why it may not be a good idea, because what happened here is actually just traumatized the iris root, which is completely unnecessary. So posterior synechiolisis may be beneficial, maybe not. But you're still not finished, because in uveitis, in acute angle closure in uveitis, you may not have got permanent adhesions formed yet, but they're starting to form. And the iris is stuck to the trabecular meshwork, it's stuck to the cornea. And if you go in with viscoelastic and just gently tease it open, you may undo adhesions that are beginning to form that have not yet become permanent. This is not true goniosynechiolisis, you're just viscoing it open. And this is probably the single thing that you can do with a surgical PI that differentiates it from a laser. And this may be the one reason why surgical PIs are better. The fact that you can actually just visco open the angle before the adhesions become permanent. So acute puberty block and uveitis It's absolute, not relative. The iris is stuck to the cornea and trabecular meshwork. Sticky aqueous means that the angle doesn't open after iridotomy. Surgical iridectomy permits you to physically open it with viscoelastic to ensure it stays open. And back to this patient, 11 days later, the posterior synechia haven't quite formed again. But the angle, it's not all open, but he does have some open angle, which he certainly didn't have before. This is a very good example of why laser PIs are not such a good idea. You've got 3 patent iridectomies here, but in fact on gonioscopy, whoops, I haven't got the gonioscopy. On gonioscopy, the angle's still completely zipped. So this patient had 3 successful iridotomies that flattened the iris, but the angle stayed glued shut. I don't like doing PIs externally. This is my favorite technique because it gives you good visibility. It requires more nibbling. It's using the vitrectomy forceps and scissors, and you can actually see what you're doing very well. So what about chronic angle closure? I don't tend to do goniotomies. This girl had goniotomy in childhood for juvenile chronic arthritis, type uveitis, and she did end up with a tube 15 years later. But the point with her is she did not have synechiae. This was goniotomy for an open uveitic angle. And Ho Ching Lin did a retrospective study many years ago of goniosynechiolisis and uveitis and found that PAS had a negative impact on success in her patients. So doing goniosynechiolisis is not a great idea. And by implication, canal procedures will be of no great value if there are synechiae. I tend to use chronic synechial angle closure as a predictor of chronicity. So when you've got the patient and you're not sure whether or not they're going to have a long-term problem, whether it's a steroid response, then chronic angle closure tells you that you're going to have a long-term problem. This is a no-brainer. The final type is forward movement of the lens IS diaphragm, which is traditionally thought to be caused by, the classic causes are VKH and posterior scleritis, neither of which I've ever seen cause forward movement of the lens IS diaphragm. All the cases I've seen have either been too much gas, too much oil, a tight buckle, or phacomorphic. The actual classic textbook cases I've actually never seen. But the diagnosis is obvious, very shallow central anterior chamber. And the most causes are actually iatrogenic. And obviously the treatment is to fix the cause, and that's very different from pupil block. And when I was training, this was poorly differentiated. The diagnosis was often badly made. People would call it pupil block when it was aqueous misdirection, and aqueous misdirection when it was pupil block. And I think nowadays people are much more clued into this. So one of my former fellows, Sonia Bennett from New Zealand, actually, without any collaboration with me, published this paper in the BJO on the outcome of peripheral iridotomy in subjects with uveitis. And Gary Holland and I were very interested in this, and we wrote an editorial at the same time. And it was very interesting because she had looked at 2,366 subjects who attended uveitis clinic in Auckland, and they had 131 peripheral iridotomies with 486 eye years of follow-up. 111 YAG, 20 surgical. Median survival, YAG, 70 days. Surgery, 11 years. So I think that's pretty clear, and I've tried to explain why that might be, why surgical iridectomy is so much more useful than YAG in acute angle closure and uveitis. And I think the message is, don't treat it like primary angle closure. You really got to treat it aggressively, or the patient will go blind. The other thing that we do in uveitis is obviously take the pressure out of the equation. So you need to be more aggressive surgically than you would for POAG. And predicting who will need surgery and who's just got a steroid response that might go away is difficult. Evidence of permanent angle damage is a strong predictor of chronicity. That's obviously a no-brainer. You know, if your eye angle's damaged, you've got a chronic glaucoma problem, and it's not just going to go away when the steroids stop. If you get evidence of optic disc damage, and this is very different from primary open-angle glaucoma, where we tend to operate in people with bad glaucoma. In uveitis, they're young patients with very high pressures, episodic fluctuation. It can be difficult to make the call. The optic disc's often structurally normal, and you don't know what the future holds. And I will usually operate with high pressures in patients with virtually normal discs, because you know it's not going to go away. And once you start to get early disc damage, you know you're heading for trouble. So you don't wait in uveitics until they've got advanced disease. You operate much more early, simply because they have much worse prognosis if you don't get on top of it. And this is a typical patient with a trab, who would have a trab on the left with very early disc damage, which you would never really be doing in primary open-angle glaucoma. So it's very different in that respect. So evidence of early disc damage. Surgery generally needs to be more aggressive. The younger patients, higher IOPs, higher risk of failure, and the stakes are higher if you don't get it under control. Certain types of uveitis have a higher likelihood of requiring surgery, especially those with some sort of infectious etiology. Herpetic, Fuchs, and the other infectious etiologies tend to be more chronic and more damaging. I tend to highlight Fuchs because it's often misdiagnosed, missed, and the glaucoma potential underestimated, yet it's got very characteristic clinical features, and it commonly causes recalcitrant glaucoma requiring surgery, and filtration surgery tends to be less effective. And this is a video I did with all the various clinical features of Fuchs that you can see on YouTube. But the point is, it's not just heterochromia. If you're aware of the clinical features, it's a very early, easy diagnosis to make. Yet I've seen so many patients over the years misdiagnosed. Cataract is the big confounder in the management of glaucoma and uveitis. And chronic inflammation is the other one. And this was a 16-year-old who was down to almost light perception in one eye from cataract, and a pressure more than 40. And ophthalmologists tend to take the cataract out because that's 90% of what they do, but the pressure's 40. If you take out the cataract, the pressure's going to be 50. You need to deal with the glaucoma first. Don't just do the cataract because it's the only thing you know how to do. You need to deal with the glaucoma. These patients frequently need cataract surgery, but you really got to be realistic about the risk of severely uncontrolled IOP afterwards. And this is not so relevant nowadays, but this was a 1990s phaco trab when people didn't really get an understanding of how difficult these can be to manage. And if you get the pressure, if you do a phaco trab and the pressure's not right afterwards, you can end up with all sorts of a mess. Typically, trabs had a bad reputation in uveitics, and this was a paper from Moorfields in the early 90s showing poor success. And tubes tend to work better than anything else in uveitics. Tubes tend to work better in uveitics than they do in anything else, but you do have to be careful with using big implants in patients who have had uveitis from early childhood, because they can go badly wrong from hypotony. But control of inflammation is everything. And with better management, when we did another audit of the uveitics in the late 90s, the success rate with careful case selection and careful control of uveitis was much, much higher. And I have done Zens and I have done pressure flows, and we've written both of these up. But overall, what I do when I'll do MIGs in those with mild glaucoma, I'll do trabs in those with severe glaucoma, and no risk factors for failure apart from the uveitis. But overall, we tend to do tubes for most of them because you know the tube's going to work. But be cautious about doing big plates in patients with JIA or very severe uveitis from childhood, because they can get into serious problems. And the pole glaucoma implant has actually reduced our threshold for tubes because the early post-operative period is more predictable than what we've had in the past. So don't reduce steroids just to take the pressure out of the equation, or don't reduce the steroids just to reduce the pressure. Operate to take the pressure out of the equation. Thanks for your